I'm Dr. Brent Schillinger, and thanks everyone for joining us here this evening. This is officially the COVID and Kids Town Hall. And it's a very good timing, you know, what we've had up to now in COVID. And I think we will continue to have a great deal of uncertainty. Early on, we heard, oh, it's no big deal if kids, they hardly ever get this. When they get it, it's not very serious. It's a disease of old people. Then appeared on the scene the multi-system inflammatory syndrome, and the question about asymptomatic spread, question about kids may be healthy, but are they giving this to their grandparents? And in recent weeks, with the number of cases climbing to crazy amounts, there's much more concern as a lot more younger people are coming up positive in the testing. Now we have the question about schools opening, schools reopening, the question about should there be remote learning, should it be brick and mortar, should it be some combination? There's a lot of politics here. Tonight, we're not here to necessarily point a finger at anyone, to point blame. We're here to focus on the science, the medical science. And it's tricky because, like I just said a moment ago, there's so much uncertainty in the arena. But we've brought together some of the top local experts in the pediatrics domain to help us hopefully sort through this uncertainty and confusion. So this is how it's going to work. Each panelist is going to speak for about 3 to 5 minutes about an aspect of COVID in kids that's most important, most challenging to them. And then we're going to have hopefully ample time for questions and answers. I've got some questions, and we're going to be soliciting questions from participants. You can do that through the chat function. Let's get right onto the program. We have as our panelists tonight, first of all, a group of pediatricians. We have Dr. Tanya Palmer from FAU, Dr. Ivy Faske, who's currently president of Palm Beach County Medical Society Services, Dr. Shannon Fox-Levine, president of the Palm Beach Pediatrics Society, Dr. Sanborn, who is a pediatric infectious disease subspecialist. We also have, I believe, somewhere on the scene here, Dr. Martha Rodriguez, who is an internist and on the Healthcare Advisory Committee at the Palm Beach School District. We have Tanya Palmer from the Children's Services Council and Dr. Elkin, obstetrician. I'll give you a little bit more background as we get to each individual panelist. Let's start that right now. First up, Adirim, Dr. Tanya Adirim. She's a pediatric emergency physician with expertise in disaster medicine and pandemics, which is badly needed right now. Professor of Pediatrics and department chair. She's Senior Associate Dean of Clinical Affairs at the Schmidt College of Medicine at FAU. Terry, give us the overview as you see things in this arena.
Sure. And thank you very much for that introduction. And thank you to the Palm Beach Medical Society for hosting this event, and to Dr. Schillinger for organizing all of us in such an important topic. It's an honor to be here with all of you, especially my pediatric colleagues. I'm relatively new to Palm Beach County. I did grow up in South Florida, so nice to be back. The topic of opening up schools for in-person instruction is fraught and controversial, unfortunately. I am tasked today with providing important information about what we need to know to date and a top-line overview of the important considerations for sending our children back to school. My colleagues will provide more details, and we can all then answer your questions. Before I begin, I thought I would relay to you some good advice about managing uncertainty in a pandemic that I found today. First, most data will be flawed or incomplete. Be honest and transparent. Second, for some questions, certainty may never be reached. Consider whether we need to wait for definitive evidence versus act on the evidence we have. Third, make sense of a complex situation by acknowledging complexity, admitting ignorance, and reflecting collectively. And lastly, different stakeholder groups interpret data differently. Deliberating among stakeholders may generate better solutions. And I want to start with an important principle, and that principle is getting all children back into school for in-person instruction is paramount. All of us can agree that we must work to make this happen. Opening schools is not just critical for our children's benefit, but also their parents, many of whom need to work, and therefore it's vitally important for our economy. We know that schools are fundamental to child and adolescent development and well-being. They not only provide academic instruction, but also help children develop social and emotional skills and provide opportunities for physical activity. And for many children, schools also provide meals such as breakfasts and lunches and physical, speech, and mental health therapies. The closing of schools has not only denied children of these vital services, but has widened disparities among children, those who are advantaged and have access to computers, the internet, and parental attention, versus children without access to these things. Children who are disadvantaged will lose many learned skills and risk getting further behind in reading and math. This is why all efforts and resources should be dedicated to reopening schools and keeping them open. However, we can't just open up the doors while the pandemic is out of control. The environment is just not safe right now in Florida, for our community, for our families, and for our teachers. It's important that as medical professionals, we advocate for the safe reopening of schools. By all measures, Florida is failing. New cases per capita is the highest in the United States, even higher than Arizona and Texas. The test positivity rate is currently hovering around 13 to 14% statewide, well above the World Health Organization recommended 5%. And test positivity is important because it helps us get a sense of how much testing is being done overall in a state or in a region. A high positivity means that really only sicker people tend to have access to tests, and we're missing mild or asymptomatic cases, and therefore we're not testing enough. Moreover, the healthcare system here in Florida, especially down here in South Florida, is strained. ERs are very busy with COVID patients, and some hospitals are experiencing consistently a lack of staffed ICU beds. And more ominously, we are seeing an uptake in the number of deaths. With regard to children in Florida, the State Department of Health released data 6 days ago, which showed that over 23,000 children under 18 tested positive for COVID, or about 0.5% of the pediatric population. Positivity rate in children in Florida is currently 13%, which is better than it had been 2 weeks ago when it was reported to be 31%, but it's still higher than recommended. Fortunately, only 246 children in Florida have been hospitalized to date, but sadly there have been 4 deaths. And 14 children have had multisystem inflammatory syndrome in children and rare but serious post-infection Kawasaki syndrome. And closer to home, Palm Beach County, there have been 1,751 children testing positive for COVID, or about 0.6% of children in the county. The third highest number of cases, second only to Broward and Dade. So this data confirms what we know from other studies, that most children tend to have mild disease or no symptoms at all when infected, and are therefore less likely than adults to become seriously ill from COVID. But there's still a lot we don't know about transmission among children and from children to adults. The evidence to date suggests that younger children are much less likely to transmit the virus to others. The thinking is that the youngest children have fewer of the ACE2 receptors in their respiratory system that the SARS-CoV-2 virus attaches to infect the host. Also, young children are less likely to have the power to propel droplets very far. There have been studies, both in this country, in Ireland, and China, to support this. And in fact, most transmission to children is from infected adults in the household as opposed to from other children. The concern with opening schools for in-person instruction now, while the pandemic is out of control, is twofold. That it could increase the risk of illness in our teachers and school staff, some of whom may be more vulnerable due to age or underlying medical conditions. And second, it could lead to an increase in or an acceleration of the spread within our community. Another concern expressed by families is the risk for children bringing home the virus to other household members who may be vulnerable. But under the right community conditions, where the pandemic is under control, and when schools take precautions as recommended by the CDC and the American Academy of Pediatrics, attending school in person is relatively safe for children. So as I said at the start, there is still a lot that is uncertain in this pandemic, but we do know some things. What we do know can help us advise families and their community leaders in the best ways to open schools. It is regrettable that our federal and state leaders did not prioritize setting the right conditions for school reopening this fall. Reopening schools is the real path to reopening our economy successfully. Thank you.
Thank you, Terry. Moving on now to Ivy Faske. Ivy is currently the president of Palm Beach County Medical Society Services. She's past president of Palm Beach County Medical Society. We've worked together for many years on a lot of these programs, communicating, educating, and of course, Ivy is a pediatrician for a long time. Your turn, Ivy. Unmute.
Thank you, Brent. Tonight I'm speaking about the importance.
Okay, I think we're having a little problem with the audio there.
All of our audio. Okay, people are moving. There
Thank you.
There we go. I'm back.
She's back.
I'm sorry. But certainly in children, the importance of the routine physical exam is paramount. Not only to get their vaccines up to date, to make sure that they we don't have some outbreak of some other illness, which is of course of concern, but also to make sure that they're as following their growth and development and issues that we know show up at 2-month-olds. And a 2-month-old that misses a 4-month checkup and shows up at 6 months, or the 4-month-old that misses a 6-month checkup and shows up at 9 months. So much happens in that period of time, and you know, parents can't be expected to see that. And of course, we're all aware of the, oh, by the way, thing that gets brought up in the exam, during the exam, and the children who are home and aren't being able to be diagnosed with you know, abuse issues and all of that. So I think the main thing is us being aware of how we can make our offices places that parents will be willing to bring their children, to make sure that they don't get behind on their checkups and vaccines, and make sure if they can drive themselves, if they can wait in their car, and make it convenient for them to call in and wait until a room is ready for them and go directly in a room, spend the least amount of time possible to get what is needed accomplished, and then go back out again. And so much now with technology can be done in advance that we should be able to do this. So essentially that was my main point, well visit, and making sure everyone stays up to date with that. I think Brent.
Okay, thank you. Thank you, Ivy. Next of our panelists is Shannon Fox-Levine. Are you back with us, Shannon?
I'm here, but I'm sorry you can't see me. I'm gonna actually try to turn the camera around because for whatever strange reason, one of my cameras is working, but not the other. Okay,
Well, give me one moment to introduce you officially.
Can you see me, first of all?
We can see you, we can hear you.
Okay.
Shannon Fox-Levine is president of Palm Beach Pediatric Society. She's been 17 years with Palm Beach Pediatrics, a group now where she is president and managing partner, which besides all of her clinical duties, she has the responsibility of a great deal of workflow and administrative processes across multiple locations. Shannon?
Thank you. Thank you for that introduction, Brent. And I think, you know, as an independent private practice, we have, as pediatricians, all nationally kind of found this, you know, relationship that we work together and we all come up with ideas and we try to help each other with the, you know, changes, daily changes initially back in March to stay afloat. And I think from a business perspective, many pediatricians were very nervous about what was happening as, especially mid-March when schools closed and the kids were going to be at home. And we saw our numbers dropping significantly for patient visits. And from, you know, that perspective of being able to remain a, you know, viable practice to service the sick children in the communities, we all were a little nervous, but we quickly responded literally overnight to implementing telehealth. Many pediatricians, you know, had used telehealth for a long time, but I think most of us struggled with figuring out how to be paid for it. So with coronavirus, that was one of the great things that came from this all happening, was having CMS, you know, have the payers pay us as we would be being paid seeing the patient in the office. Mental health, we do a lot of mental health, as I know many pediatricians do, and that kept us afloat for those first 2 or 3 weeks where parents were scared, and believe me, we were scared too. It took us easily a month to get the PPE that we needed to really, feel comfortable to see patients in the office, sick patients. So fortunately, with us having multiple offices, we were able to divide our offices up and have well visits only at 2, which to this day we're still doing. 2 of our offices have only well visits, and one of our offices at that time had sick only. But with the social distancing in place, the greatest thing that we saw was that there's very little illness that we were needing to see in the office. We also were struggling with how to decide who to see in the office for illness, and trying to really limit how many fever, cough, sore throat, congestion kids we were seeing, to, again, not expose our staff, at least initially. Now, with telehealth, we've managed to be able to navigate with some of these families what they can do. In the meantime, before we really get to a point where we feel like we have to see them in the office, the sick volume for us has dwindled to the point where we've actually opened up that one office that was only sick to only a half-day sick in the afternoon. Nationally, I think many pediatricians with fewer offices are doing something similar, where they see well visits in the morning and sick in the afternoon. I agree with Ivy that we've had to really sell this to parents, that we are a safe place for them to bring their children. We need to keep their immunizations up to date. It's, very important for their health and, for the world's health, basically, especially at this time, to keep their immunizations up to date. So we have worked very hard to communicate with our families, which I think is very important, through emails, through Facebook, to let them know the changes that we've put in place to make sure that they can feel safe when they come to the office. And those change constantly. So that, I think all of us are, struggling most with, is that just being on top of all of the latest and the greatest with the information, and trying to interpret the data the best we can as medical professionals to then make best practice decisions, to keep our staff safe, to keep ourselves safe, to keep our patients safe. So this has been, again, nationally, I know through talking to many pediatricians that have independent, privately owned practices, they've been in the same situation as we have. And again, that's the great thing, is the camaraderie and all of us working together and sharing ideas. And I also feel that, as we kind of sell kids short, and we say, well, they're never going to wear masks, so can we have them come to the office because they're not going to wear masks? Okay, I'm here to say that, all summer I've been seeing kids, and now I'm quite busy seeing 25 kids a day with all the school checkups, because the private schools in Palm Beach County are starting as usual. So these little guys wear their masks, and to the point where I have to ask them to take their mask off just so I can examine their nose and their mouth. 4 and up, it's amazing what kids will do. They amaze me every day, and that's why I love what I do. I love my job, and that's all I have to say. Thank you.
Thank you, Shannon. Okay, thank you very much. Next up on the panel, Dr. Chad Sanborn. Dr. Sanborn is a pediatric infectious disease specialist. He's with Kids Medical Services. He's based out of West Palm Beach, but from what he tells me, he's all over the place, all over Palm Beach, Broward County as well. Luckily, we got him tonight to be part of our program. Dr. Sanborn.
Excellent. I hope you can hear me. And if the video is not working, I apologize. I was having some issues earlier. But so from the pediatric infectious disease world, in the hospital world, we certainly are seeing kids with coronavirus infection. Our numbers in general in the hospitals have decreased in all of the children's hospitals in the county. And that's pretty consistent in Broward, and what I'm hearing in other places as well. I think it shows a pretty good example of when you keep kids separate quarantine, you get less infections and less hospitalizations. You know, right now we have the capability still as of today, that may change soon, but we have the capability to test all children. So we're trying to test all admitted inpatients in the county. And the rationale is kids can present in such a variety of different ways. We want to be able to capture all those kids. And for the staff's standpoint as well, we want to be able to wear appropriate protective equipment when a child is positive. So we're testing children who get admitted to the hospital, and we're finding that we are increasing in the amount of positivity we're seeing. But in general, you know, the majority of kids who do get admitted are not very sick, which is great. You know, a few have required oxygen and some have required intensive care unit stay, but by and large, it is a relatively mild illness in children. And even the hospitalized kids, they do fairly well. You know, for the kids that go home from the hospital or from the emergency department, we do offer, if the provider feels appropriate and if the clinical scenario is right, send out testing. So, you know, we're doing send out testing, which takes a little bit longer to come back. That period used to be about 48 hours. Now it's getting 3, 4, 5, up to 10 days to get results, unfortunately, to Quest and LabCorp sometimes in this send out testing. You know, we have seen in some of our inpatients, pretty similar to the adults, respiratory illness in general. For kids, we are seeing a fair amount in young and older kids of GI symptoms, things that mimic appendicitis or act similar to some of the severe gastrointestinal illnesses, which you wouldn't expect necessarily from a respiratory virus. And, you know, recently, over the last 2 weeks, 3 weeks or so, we're seeing a fair amount of urinary tract infections associated with coronavirus. You know, I don't know, that hasn't been published. I haven't found much data suggesting that in other parts of the world or country. I have to, when I get a few free minutes, to sit down and actually look at the data. But we are seeing a fair number of kids who have coronavirus and either proven urinary tract infections or urine type symptoms, i.e. pyelonephritis type symptoms, flank pain, belly pain, things like that. And then going on to this post-infectious multi-system inflammatory syndrome in children. You know, we are seeing several suspected cases of that. You know, in the county, we've had about 12, 13 suspected MISCs total. A few are proven, meaning you get an antibody test positive or a PCR test positive. However, many of them aren't quite proven, and some of them don't seem to make sense, don't fit into any other diagnoses. For some of these kids, we have treated them with IVIG, and they have responded to it. So, you know, there's still a lot of questions to be answered. We certainly think this MISC is linked to COVID. However, in other parts of the country and the world as well, they have not seen 100% correlation. So some of these kids test negative for coronavirus, yet seem to have these similar symptoms. So I don't know if that's a factor of our antibody testing not being great. Kids present with different antibodies than adults might, or we're looking the wrong path. Maybe there's a different antibody entirely we need to check in these children. But we are seeing a smattering of that. So, you know, by and large, I think the kids, I agree with their previous speakers, do get a mild illness. I think the kids do pretty well when they do have more of a moderate illness, fortunately. And we're not seeing too many severely sick kids, which is great. You know, the concern moving forward is that as cases increase, that number of, if there's a small percentage, you know, 0.5 to 1% of kids who get a moderate illness that requires a hospitalization, you get enough kids infected, that's going to quickly increase and potentially fill our children's hospitals in the county, which would be a problem. You know, there's a lot of questions we don't have. I agree with Dr. Fox-Levine. Sometimes we feel we don't have the answers. We try to give our best guess based upon the available information, but we're working through it. I feel the families are, you know, anxious, but understand that there's still some knowledge gaps and trying to fill in the information. But in general, yeah, we are seeing a increase in the number of hospitalized pediatric patients, but in general, they are still doing well.
Okay, well, thanks so much for that summary there. Thank you, Dr. Sanborn. Next on our panel, Martha Rodriguez. Are you with us, Martha? I see a Rodriguez, but I don't see Martha Rodriguez, so I'm not sure if she's on the call. So we'll see if we can come back to her. Tanya Palmer, I know Tanya is here. Okay, Tanya is Chief Program Officer for the Children's Services Council here in Palm Beach County, a group that Medical Society works with closely. In fact, the original founder of that group, okay, Elaine Alvarez is on our Board, Medical Society Services. So we're very close to what goes on with Children's Services. And Tanya and her agency, Children's Services Council, is an agency, for those of you who are not totally aware of that, that funds and supports programs here in Palm Beach County specifically for a number of levels, including specifically pregnant women, children, and families. Tanya?
Thank you. I appreciate the opportunity to speak with everyone. I wanted to kind of come at it from maybe a different perspective and recognize that when we think about COVID and the impacts of children, we know that children operate in the context of families. And so while I think everyone is rightfully concerned about the impact in terms of the illness, what we also recognize is there's very much sort of the economic uncertainty that is accompanying the situation. And so my suspicion is that some of the families who may be approaching the medical home as a source of care and a respected source may also be presenting with some issues that are causing stress as it relates to economic uncertainty, potentially have either been furloughed, have lost their jobs, or have looked at reduced hours. And so we recognize both the stress that places on the parents and then the impact on the children living within that sort of stressful environment. So one of the things I just wanted to cover a little bit today is talking about some resources that some of you may be familiar with, but may not be, or maybe it's just a good refresher. So when some of the patients maybe come in expressing concern, anxiety, because maybe they are worried about possibly becoming homeless at some point in time as the eviction protection goes away, or worried about not having enough money in order to, have just sort of basic food and food insecurity, where do you go to? And I'd love to say that there are an abundance of resources. That's not necessarily the case. It is a situation where there are resources available, but in a lot of cases, it is sort of a patchwork. So relying upon some existing strong federal and state programs, as well as in some of the informal safety nets. So when families do present and have a lot of anxiety and don't know where to turn, I would definitely encourage everyone to be very familiar with 211. It is our county's information and referral resource. It can be a great starting point for families. It can help them address, if they are struggling with economic challenges, trying to understand more about some of their backgrounds and be able to direct them to the appropriate public benefits. Some of which will be programs that you're familiar with, like Medicaid, food stamps, and TANF, but other programs that you may be less familiar with that are available through the county that can help with rental assistance or utility assistance. 211 also can be a really invaluable resource for families or caregivers who are feeling just very panicked and stressed. We know after talking with the executive director that their call volume has doubled and tripled. In a lot of cases, they're spending time just reassuring the caller and sort of talking them off the ledge and having them kind of come back to a sense of normalcy and be able to re-engage with their child or whatever else is calling their attention. We also recognize, and I appreciate the Dr. Faske and Dr. Fox-Levine who said that, with concerns about showing up at your medical home, there's probably been a delay in families getting immunizations and or their developmental assessments. And so we recognize this is also a time when families are stressed, that we may see some developmental delays with children or possibly regression in behavior. We know that even normal circumstances, parents typically are always kind of struggling with the question of, am I doing the right thing? Is my child doing well? And developmental screenings can be a really nice opportunity to understand what the child is capable of and if there are any areas of concern. So if there's ever a point where you as a pediatrician need additional support in either administering the developmental screen or following up with a family where the screen has indicated that there is an issue of concern, Home Safe is our entry agency to our Healthy Beginning system of care. They're able then to make a referral to a broad network of providers who can provide developmental support, nursing home visiting, if we're dealing with a pregnant woman, or maybe an infant who was born premature. as well as other support services that can help support the parent-child bonding. We know that's critically important. And if we've got families and parents and caregivers who are stressed, sometimes their ability to engage with that child becomes impacted. So at the end of this, we'll figure out how to make sure that we can send out resources in terms of phone numbers, as well as other ways for you to be able to have those kind of contact information at the tip of your fingertips. But definitely want to continue to encourage that we use every opportunity to pay attention to what is happening with the development of a child. As Dr. Schillinger pointed out, a lot of our focus is on the 0 to 5 population, but we do provide services to all children. We know that teens are definitely being impacted at this point of time as well. Some of the social isolation, maybe even more likely to act out. A teen that maybe hasn't been giving their parents problems before may all of a sudden be a very challenging situation. And we do have Teen Triple P available in this community. Both the Center for Child Counseling as well as the Center for Family Services can provide that support and really works with parents to help them figure out the best strategy to help with a child who may be acting out, disruptive, or is dealing with depression. And then the other thing I just maybe want to touch on briefly, but maybe we'll come back to it later, is we recognize as the likelihood of us going back into virtual learning for a period of time. As Dr. Adirim pointed out, this has the potential of exacerbating some of the academic achievement gaps that are experienced, especially with families who are having challenges with having adequate computers or internet connectivity. I'm not sure how many of you are aware of some of the resources that are being put into play, but the school district right now is in the process of purchasing up to 80,000 more computers. It is their intention that every child be able to have a device. We are aware of situations where families with multiple children have had to share a device. So that will hopefully not be an issue for long. They'll be receiving those devices in mid-August, and they'll be receiving them over the period of 6 to 8 weeks and trying to get them out to their highest need families. So if you do have families who are presenting who have expressed concern, let them know to reach out to their principal to make sure that they are on the list to get the device. As well as there's efforts underway to help sponsor internet connectivity for families who are not able to afford it, as well as make available devices like Wi-Fi, as well as on a rolling period of time over the next 4 to 5 months, trying to bolster the broadband access that will be available in some of our more isolated communities. So lots happening. I think we all continue to be very concerned about just the overall stress, especially as this is a protracted period of time. And so again, would encourage you to be familiar with 211, Home Safe as a resource for developmental screening. And then the final thing I should have mentioned is we do know that families are having to return to work. They may be very concerned about who is going to watch their young child, especially if school is going to be in virtual for an extended period of time. And definitely would encourage you to be aware of the Early Learning Coalition. They are our centralized childcare resource and referral agency within Palm Beach County, can work with parents of all income levels. So for parents who can afford childcare and don't know who's open or what to look for, can help make those connections. And for families who aren't able to afford childcare, can work with them to get them access to subsidized childcare. And we'll make sure that we get that phone number and contact information out to everybody at the end.
Thank you so much, Tanya. You know, as physicians, we don't realize sometimes how critically important it is to be able to partner with an agency such as yours. You know, we're learning how important the social determinants are in terms of healthcare, and we can write a prescription and say, yeah, go take care of it. It doesn't end there, obviously. And we will be posting on the Medical Society website the resources that you referred to, so we'll have all that information available. And I also must say that as we learn the technology, we found out that apparently Zoom, although we have an account that's supposed to give us up to about 500, has limited this meeting to the first 100 to sign on, even though about 240 signed up. So there may be some of you listening who have not gotten onto the platform. And I need to tell you that we will make the entire program. We're recording it. It'll be available for everybody as of tomorrow. So keep that in mind. Moving on to last but not least amongst our panelists, Dr. Aaron Elkin. Aaron is OBGYN who actually practices the OB part of OBGYN. He is based out of Hollywood Memorial Hospital. He's done so many things. I've spent time with Aaron over the years. He's done a tremendous amount of things in the Government Affairs Division for the ACOG, American College of OBGYN. I know he spent a lot of time in DC, and he tells me he's one of the few obstetricians who has delivered or been involved in a lot of deliveries with COVID patients. So Aaron, please step in and tell us what's going on in the pre-pediatric scenario.
Okay, so good evening, everybody. I'm so happy to be here. Can you guys hear me?
Yes.
Okay. So, you know, I think I like to start with the fact is that when we talk about pregnant patients, we talk about not just pregnant patients, we talk about families. So you talk about an entire household. So to set that in place, when we are taking care of patients, we are not taking care of just the pregnant patients. The care of the pregnant patient affects their family, their children, their past, you know, their cousins, their entire household that may be in contact with each other. So to understand when this pandemic occurred, you know, when it started out, we thought initially we didn't really know much about that. And certainly when anything starts out, especially if you don't really understand what the disease process is, you really don't know how to address it, how to test for it. So going back in time in 2016, we had what we call the Zika epidemic. So Zika as well is an effect that occurred in South Florida, primarily in South Florida, and started over here. And at that time, the government attempted to try to help physicians and try to do research on Zika in order to try, prevent it from transmission to the mother and potentially the baby, and furthermore, to do testing on it. And just to give you a perspective of how slow our care is, until today, even though we have a Zika IgM test, which tells us that perhaps they got the Zika virus in the last 2 weeks, we do not have a Zika IgG test. And I want to go back to now to COVID. And as you know, this is a little bit different, but they finally got both IgG and IgM testing. Now, why am I starting to talk about that? Not having the virus and potentially have an infection that affects the whole household, we can't just do snapshot testing. We need to also look at the future, whether somebody was exposed to it or not. So what do we find about pregnant patients? So far we know that pregnant patients appears to be a little bit more of an increased risk for severe disease. Mortality appears to be the same. There appears to be very little vertical transmission. In fact, you know, just about all the babies that I know of that delivered in the hospitals that I work in are COVID negative. So the transmission of COVID usually occurs, as you know, not necessarily by vertical transmission, but by contact. So what the American College of OBGYN has done is to look into how do we take care of a pregnant patient when she's either in the office or in the hospital, and what happens when she goes home. So when you look at real time, when this whole pandemic started to occur, we all got thrown into ourselves into how do we actually take care of patients. So taking care of a pregnant patient means that you need to take care of the patients, both in the office and in the hospital. So what happened in the office? Because we start in the office and the pediatricians here, the physicians, we don't have supplies. So I'm going to make this simple because I think visuals is a little bit better. We couldn't get toilet paper, okay, to take care of the pregnant patients that come and see us in the office. We couldn't get masks. We still can't get masks. And even if the masks that we get, there may not be N95 masks. We cannot get gloves. We had a shortage of gloves, starting taking care of all these patients we had to go everywhere in the United States. And what the government did, we had a shortage of, I know it sounds crazy, but there we go. Sanitizing to be able to see the pregnant patients or the pediatric patients or the regular patients in their office. We cannot get sanitizing for our offices. These are things that have affected, and I know I'm kind of talking about this in a very passionate way, but one of the most difficult things that this has done, because we have deficiency in the ability to take care of patients, whether they're pregnant or not, we simply were not able to care for them and be able to even support our offices. So we started to do telemedicine on some of these pregnant patients. Why? And the American College of OBGYN starts stating that you can actually reduce the number of visits. So in the offices, we started to do that. And I think when you look at pregnant patients, treatment in the office is very different than treatment in the hospital. And in the hospital, I will tell you what is happening. Right now, it seems to be that whether it's the first curve or the second curve, the peak is the ICUs are almost at capacity. And what's happening is that we really can't take care of the pregnant patient, the pediatric patient, unless we isolate them. So every pregnant patient that shows up at the hospital and gets admitted, and any patient that gets admitted gets a COVID test. And the COVID test is a rapid test. And I want to explain to you that sometimes we run out of reagents for that test. So you have a patient that's pregnant, they're coming into the hospital, getting admitted, and she may not be. Sorry, I got unmuted. I think that, what has happened because of that, we institutionalize a way to actually isolate them. And if they're COVID positive, then everything else changes. When they're COVID positive, both for the doctors and the patients. So the patient themselves, get isolated and they can't be with their partner because we don't know if their partner is positive. So all these patients gets admitted now to the hospital and they're positive. They can't have their partner. They have difficulty seeing their babies afterwards because while there's some data that shows the babies may not be positive, we don't know what will happen when they go home. So they sometimes actually go home now without their babies. But what is the most difficult thing is that, and I want to tell you a little bit, is the healthcare workers that are taking care of the pregnant patients. We have a lot of difficulties with getting supplies. The supply issue has not gone away, whether it's in the office or in the hospital. But what also happens is the exposure of pregnant, of doctors to patients in the hospital increases their risk of coming out with symptoms. I do want to point out that the CDC came out with on July 22nd, which I think it was an update on July 22nd, and they looked at healthcare workers and how healthcare workers, and I urge each one of us to go into, just Google CDC healthcare worker, and you would see the updates of what we know about the COVID. And I'm going to just tell you one thing, and then I'm going to let somebody else talk and ask questions. We know now that the COVID virus may be isolated in the respiratory, in the respiratory secretions, but after 10 days, that key is 10 days. This is based on evidence-based medicine. After 10 days, the concentration decrease. And after 10 days, if you only are asymptomatic or you have you have very mild symptoms, even if you can isolate the actual virus, it's not a transmissional virus. So we know that 10 days is a critical thing for us to look at whether we are able to either quarantine ourselves, be with somebody that's COVID positive or not, and we can address that later. But that's a critical thing. So they came out as of this last Friday, with a new statement that you do not have to have testing to be negative to be able to either return to work or be in contact with somebody else. So the 10 days being at least 10 days from the onset of your symptoms or somebody else's symptoms, more than 24 hours of fever, and improvement in symptoms, in the respiratory symptoms. Now, I think that that's important for us to know because it both goes to, I'm going to stop after this, it goes both into the treatment of, of patients, and how do we deal with people that are going back to school, and how do we deal with a household? How do we deal with contact? So I have lots of other things to do to you, but I can speak for an hour and a half. I just wanted to stop there. Oh, by the way, temperature needs to be taken. We instituted in our offices. This is critical. We have a very important policy where everybody gets their temperature taken. This costs about $50 now in the age of COVID. They need to make sure that they're symptom-free. And if they are not willing to do that, I had a patient that told me she thinks that this is going to cause her a brain tumor because they told her that at the gym. We do not see the patient. And I think that one of the things that we do, we need to protect ourselves in our offices. So I'm going to stop right there, and that's it.
Thank you. Thank you so much, Aaron. A lot of information from all of our experts there. I want to just take a moment to thank someone who's on the program tonight, Dr. Elena Alonso, who heads the Department of Health here in Palm Beach County. We're glad to have you here. You always see Dr. Alonso's name in the newspaper when there's some sort of controversy, but I can tell you she does a fabulous job of balancing all the pieces. And I'm sure she's hearing some interesting things from everyone here tonight. Thanks for being part of this. Now we have some time for some questions, and you can send your questions in the chat, and we'll try to get to some of those. The first question that I have here is going back to something that we heard very early on this evening. Is there so much data out there concerning the transmission from children, between children, and what are we supposed to take away from that? Just in the past week alone, there's been so many different studies. There's the studies from China, the study from Denmark. In Pediatrics, they published that one study from Switzerland, which gave us all a perspective of, oh, there's not that much transmission. Apparently, at least that's what the headline said in the lay media. And then there's a study from Korea with something like 40,000 contact tracers. And the takeaway in that just seems to me, it depends who it is that wants to make their point. They'll pull something out of one of these studies and say, see, it's not so serious, or see, yeah, there could be big problems. So I'll throw that question to Dr. Adirim, because you're the most academic amongst us. What are we supposed to understand from all this confusion, all this uncertainty?
Right. Yeah, well, it's the nature of pandemics and new novel virus to have this uncertainty. So I'm not surprised, and I don't, blame people for reading into these studies what they want. I will say I do look to my infectious disease colleagues. I have read the literature, and me personally, if we were in a community where the case rate was low and my school for my kids took the right precautions following CDC guidance, which is pretty good, pretty detailed, I would have no problem sending my young children to school. And that said, if you were to, I've read the CDC guidance for schools, and I'm not surprised that anybody would criticize them because they are very detailed and they do take a lot of resources to restructure the classroom and to provide all those things that are necessary in order to maintain social distance, in order to ensure that everybody's wearing masks, that used for alternate sites, and so on. And it goes into great detail. So I think that that we have the tools to do this, but our public health departments and our state government really needs to help us with this by intervening to decrease the number of cases within our community so that we could make the environment right for us to open the schools. I think on balance, in the right conditions, that it's much more important for our children to go to school. It is so critical, weighing the pros and the cons. That's I guess that's it.
It's not going to be an all or nothing issue. Obviously,
Right.
we have to strike
Right.
some important compromises here. So speaking of data, and I'll throw this to Dr. Sanborn, do we have data that truly shows that COVID is really not that serious in children?
So, you know, the data gathered from the United States so far, which is pretty similar to what we have in Palm Beach County, is that the majority of, vast majority of childhood infections are going to be very mild, right? So, which is good. I think I agree with some of my colleagues saying that, yes, young kids really shouldn't be very affected by this. The majority of the hospitalizations we see are in children less than 4. But potentially that could be explained because, well, we hospitalize kids less than 4 for many other common things, more so than we would for a 12-year-old, for instance, right? However, there's still a lot we need to learn about this. And I think in a scenario here in South Florida where numbers seem to be going increasingly higher, and we're finding out data that, you know, some of these kids do get some relatively sick, you know, I just get concerned, and I do agree with, I think it is better for kids to be in school in general, but for certain high-risk kids or just, you know, children who potentially could be healthy without other predisposing conditions could unfortunately end up requiring hospitalization. So it's a hard balance, and there's no absolutes, open everything up versus not in terms of schools. I think each family has to make decisions with their physicians regarding that. But yes, we are seeing less severe disease, and potentially we're quicker to hospitalize a child with coronavirus than with some other illnesses. But there's still so much we need to know about this and learn about. We didn't think kids got affected at all, and then we found this multi-system inflammatory syndrome in children, right? Is there something else down the line? I don't know. Who's at risk for multi-system inflammatory disease? We don't know. So there's more questions than answers at the moment. So it does give us time to maybe pause and try to figure out what the best approach is moving forward.
So going to our clinical practicing pediatrician, primary care pediatricians, obviously you're going to get that question quite a bit from parents, this whole thing about the return to school situation. What kind of advice do you give? What kind of advice can you advise your colleagues on giving? And I throw that out to Ivy or Shannon, or both of you.
I'll start. I'll just turn my computer around here again and say that, you know, I think, again, as I mentioned earlier, the private schools are going back to school, you know, very soon, the next few weeks. They're all gearing up to go back. And they have all of those CDC guidelines in place. And, you know, it's pretty impressive what they've pulled together. Now, granted, they're financially able to do that. And I understand public school. So that's, you know, something that I think that, you know, as a community, we need to really fight for with the state to, you know, put more money into these resources to get the kids back into school, to have, you know, school nurses at all the public schools to be able to help us navigate some of this. The you know, issue with testing is just, it's like mind-blowing, because we really, you know, can't get test results. So how do we send kids back to school if we're not going to even be able to test them if there is a concern of, you know, a child with a fever and a cough? We're lucky to get results back in 12 days at this point from sending them out to Quest or LabCorp. So the you know, point of care tests for us in primary care, we're not getting those until, you know, late August, September, October. So, you know, this is, and we're the ones that are going to be seeing these kids when they go back to school. So I've been telling people that private school for us here in Palm Beach County is going to test the water for public school, since public school is a much larger animal to try to figure out how to, you know, have the resources in place, and what the private schools are doing that is working to be able to then implement in the public schools. Families ask all the time, you know, what I think about their kid going back to school. And I think it's really, really important, as we've all been saying. A few weeks ago was really advocating for it until the numbers in the county started to climb. And then, you know, it's difficult to tell people that, you know, they should send their kid back to school as they're watching the news and they're seeing that these numbers are getting so scary again in our area. So I understand parents' apprehension, and that's why I really think everyone should have a choice. And that, you know, a choice would also create social distancing, because a good chunk of parents would keep their kids home virtually, and then the rest would send them to school. They'd be able to be 6 feet apart. There's many states that are doing this. They're very complex, you know, 40-page detailed documents of how the states are doing this for their public schools. So I think it's doable once we can at least see our rates decreasing in the area. So that's kind of, you know, the caveat that I throw out to the parents now. Granted, private schools, these kids are going back, and these families are happy to go back. I have to say that through the months now, I have more parents who want their kids to go back than who don't, and teachers who are just angry that they're not going back to school. And I know, you know, that's of course my population, but again, I see a lot of people all week, all through the summer. So, you know, in summary, I always leave it up to the families, because again, I do feel that they should all have that choice to make for what they think is best. They all know their own histories, you know, family histories in their homes. What if they live with, you know, a grandmother who's immunocompromised, or what if the mother's, you know, got cancer and is on chemotherapy? I mean, all of those issues are going to play a role. And I don't think really as pediatricians, I mean, we can have the discussion and help them sort these things out, but it ultimately should be up to the parent themselves whether their child goes back.
And Ivy, what's your take on this?
Beautifully stated, Shannon. And what I was happy to hear tonight from Tanya is that the school is able to come up with more computers to give to people for children who don't have the computers. So those parents are able to make decisions for their children, just like all the other parents. So they can decide if they think it's best for their child to learn outside of the brick and mortar, and be able to by having computer access and internet access. So that was really good news. But really, it does come down to the parents, and they have to look at everything, you know, in their family life to figure out what's best for their child. Yeah, so it's nice that everyone is able to hopefully now have the ability to make a choice.
But when they come to us for our advice, they're going to listen to what we say. So how do we guide them?
That as Shannon stated, it's multifactorial. You have to look at your child's medical history and decide if you feel your child is more at risk. Does your child do better learning in person versus learning online? Is your family a large family living in a small area with grandparents who have underlying medical conditions, and maybe you don't want to take those risks? So I think we can sit with them and help them sort through, but at the end of the day, they have to make the decision. But yes, I would, things were great and the numbers were down. I would love to see children go back to regular school. It's what kids are meant to do, right? So.
And Tanya, at the Children's Services Council, have you been approached already by parents who are concerned with their choices and how they can manage that?
We ourselves have not been. I would say I would agree with both what Dr. Fox-Levine said and Dr. Faske, is it really ultimately has to be a decision that a parent feels comfortable with. We would try and point them to the resources that would let them sort of guide that decision-making process. And one of the resources that we'll include in there is our Every Parent palmbeachcounty.org on the website, and Every Parent app, where we do have a compilation of just locally resources for parents, including what's sort of the latest information on COVID. But I would agree, I think, and from our perspective, we do believe that needs to be guided by what they have spoken and shared with their pediatrician, and then factored in what makes sense for the family's circumstances and condition.
So there's a lot of moving parts. It's a multifactorial formula here. So just moving into a couple of other areas. One of the questions that comes up frequently now is testing for children. Who should be tested? Should every child be tested? And what type of tests should we be looking at? The PCR, or should it be antibody or antigen testing? Who would like to answer that?
I could speak a little bit about that here. So yeah, I generally would encourage, it would be wonderful to have testing on everybody just to know numbers and stats and so forth. But from a practical standpoint, if most kids are going to have a mild illness, I don't necessarily suggest that a family go to get their kid tested unless it's going to have some impact potentially on, someone who's sick at home, or whether an employer is requiring it for a parent to go back to work. The issue is that the turnaround times are much too long. It's difficult to get a test. I actually had a case where a family member, a teenager, and the parent went with a sick relative to get tested at a public site. They waited in the car for a long time, and the other two individuals ended up getting infected. And that's unfortunately what we're seeing. I know it's one case, but I think that's happening more often. So, I wouldn't suggest to families that they run to the hospital to get tested because, well, there's not necessarily enough supplies, testing, turnaround time to be able to do that effectively. PCR is best when someone is acutely infected. There are a number of IgM, IgG antibody tests that are marketed on the internet. Most of them aren't necessarily well approved or studied, so we don't know how good those are. Potentially IgG tests are good to see if you've been infected in the past, which potentially would be something which would make a decision whether you can be a plasma donor or not. But even an IgG positive on a test that was sent out to a commercial laboratory wouldn't necessarily mean that you're free of getting disease in the future and should be able to go about as if you have a get out of jail free card from this. So it's a difficult scenario at the moment.
I would just like to add to what Dr. Sanborn's excellent answer is that I agree that under the current circumstances where testing is not readily available and where there's a long lag time to results, it doesn't make sense to test every, person. However, when we do get to a point where our testing is more available and we get our results within 48 hours, I would recommend that everybody, including children, get PCR tested so that we can do contact tracing and we can extinguish any new crop ups, any surges and prevent those from happening. I would say about antibody testing, thankfully in the beginning of May, the FDA put out notice that all antibody tests have to be under an emergency use authorization. So prior to that, there was over 150 companies selling all kinds of BS tests that were not good at all. They were horrible tests. I would say now the antibody tests are now pretty good, typically over 95% sensitivity and specificity. However, that said, as Dr. Sanborn said, most of those tests, almost all of them, don't quantify the antibodies. They don't tell you which antibody, if it's a neutralizing antibody or, the protective kind versus other types of antibodies. And it won't tell you whether or not you would be protected from getting sick again. So it's really only being used at this point for surveillance and for donation for plasma. So I don't recommend that people use it as a get back to school kind of thing. So
on the test,
I want to make a comment about testing really quick.
Sure.
And I want to add to that. I think it's an excellent discussion, but going into perspective, what we learned before, and we all know as practitioners, that first you develop an IgM antibody, and then in reaction to a virus, or and then you develop the IgG antibody. What's interesting about COVID is that the IgG and IgM antibodies, the IgM antibodies may be positive, and the IgG may be positive or negative, and you may still actually have the virus. So they found out that the typical 2 weeks curve that we normally say 2 weeks positive IgM, and then you have a positive IgG does not work for COVID. And because of that, that creates a problem. But I want to repeat the role of serologic testing as of the CDC guideline in last Friday on July 22nd. Was it July? I think it was July 22nd. Well, I think it was it was updated, I think, today. Serological testing should not be used to establish the absence or presence of COVID infections. That is CDC guideline. So until we know more about it, It's kind of like experimental. It gives us some data. But I want to point out the fact that if we test every individual, even if we do, it's a snapshot in time. The child or the adult can go to another party or be in contact with another person the following week. And even if they had a negative test, we need to retest them and retest them. And unfortunately, I think that one of the guidelines that have occurred, that people that are asymptomatic, is to watch them without symptoms and not test them. And that's the same thing that happens when you are asymptomatic and you have a partner at home, a husband, a wife that was positive, and you're in contact with them. What do if you have no symptoms? Do you test yourself? Do you not? Do you turn back to work? So there is a way to do testing, and there's a way to just follow it by symptoms. The problem that I see, that I don't know if anybody raised, is the fact that if a child goes to school, contacts COVID, and certainly the younger you are and the healthier you are, the likely you are to be asymptomatic and the shorter disease. But what if that child now comes in contact with its grandmother or his caretaker that has diabetes or his teacher that has diabetes? So I agree that children should go back to school. I just don't think we have everything all hunky-dory where we can say, well, this is the mechanism. And it was interesting to watch on TV a discussion about two different school systems, one in Virginia and one in Dade County. And to look at Virginia wanting to establish half of the time in school because they want to have some social distancing, and in Dade County they didn't want to do that. So there's no perfect way. I agree we need to go back to school, but at the same time, each parent or each individual needs to decide whether they do the testing because it has consequences, or they're not exposing that child or the adult to somebody who's frail or maybe in that same household. That's my only statement about that, because you can do a test today, but tomorrow it could be positive.
Of course. So while we're talking about testing and the return to school, what about the concept, which we hear a lot about lately, pooled testing, in an effort to make it more efficient? Is there any possibility that might work with the schools, pooled testing, where maybe you do each classroom every couple of days or something along those lines? Terry?
Well, pool testing is effective when case rates are low because it's based on being able to do a group of people and hope that everybody's negative so you can move on to the next group. If they're, and I don't, school situations may be different, but in our current environment, if you were to do a group of people, the chances of having at least one positive would be pretty good, right? So then you have to test everybody anyway. So in the school environment, I suppose it could work. I've been advocating for it for my university because I'm on the planning committee for our university reopening and doing it for the dorms. But the concern would be then, you know, that amongst that age group, it probably is spreading like wildfire, right? Because the case rate's so high and transmission so high in our community. It's a great tactic. But my concern would be that in a place where the transmission is so high, it may not be as effective. But that's.
I would concur with that. Yeah. I would concur with that. The rates in Florida, you know, our rates are too high. You end up doing more tests, longer turnaround times, unfortunately. Right. And maybe per school, it may be a little bit different, or in a smaller setting, or hopefully in the near future, if and when numbers go down, we'll be able to do that effectively. But at the moment, I agree. Yeah.
So we'll switch to just a very simple question in terms of the PPE and the recommendations for children wearing masks. Ivy and I were speaking about this previously. How do we get kids to wear the masks? Are there other options? What's been your experience there? Dr. Faske.
You know, I know I spoke to Dr. Fox, Shannon, about this, and in her population, she seems like she has really good results with her patients keeping their masks on. And I find that, you know, mine are, it's very borderline if they're below the age of about maybe, you know, 7 or 8. And I wonder about the really young children, you know, that they, you know, it's really hard for them. And I was thinking maybe those little shields that you see, the little bucket hats with the shields on the front. And granted, it doesn't, you know, they can still touch their face, but at least if they sneeze or cough or right in each other's face, at least there's some sort of something between them and the next person. And the chance of maybe a little kid keeping something like that on might be increased. And I don't know. But you're right, they put their hand up to their face underneath. If they just wash their hands more often, does that override that they do that? I don't know. Oh, look, Dr. Adirim's got her mask.
No, kids love masks, and I don't remember who said it about kids wear their masks. I mean, we all know this as pediatricians, that in the school age group, especially, you know, the age about 6 to about 12, you know, they're rule followers, right? They're going to wear their mask. And you know, some of the tactics that I've used in some kids has been, you know, let them pick their mask. Like, this is Hello Kitty, like my daughter would steal this, right? You know, let them pick their mask, get excited about it, practice wearing it in the weeks before school starts, so they get used to the sensation of wearing a mask. And so those are some of the things that I usually recommend, but I have a Hello Kitty mask. I'll wear this. I'll wear it.
So I think the point is kids look to see what their parents are doing. They like to follow what their parents are doing. So if you have a parent who's wearing a mask and not complaining about it, maybe the kids are more likely to wear their mask as well. But if they have a parent who's complaining, and you know, maybe that can be an issue.
So some simple little tricks might make a big difference. So I think we're getting somewhere near the end here, but we have time for a few more questions. And I'll direct a question to our OBGYN guy. So Aaron, is there any data that shows that pregnant women develop more severe COVID infections, but have different risks? Have you found that amongst your patient population?
You know, anecdotally, there really isn't anything that I have seen. There appears to be a slight increased risk for a pregnant patient to have severe illness. Slight increased risk is also occurs in any pregnant patient that has a medical disease, including the flu and the common cold and so forth. So diabetes and so forth. Anybody that's pregnant that has another medical an illness have an increased risk. So there is a slight increased risk, but mortality is the same. What is interesting that we found, it seems to be that there are more pregnant patients. If you're pregnant, you're more likely to be diagnosed with COVID, but it could be also incidental because we're doing more testing on those patients, especially when they come to the hospital, because nobody can be admitted to the hospital when they're pregnant or any other admissions. So we do tests for them. There really isn't any increase in mortality. Do we see mortality? Rarely, but it can happen. When they do have severe disease, all the processes of pregnancy. In fact, the American College of OBGYN has recommended, in a very unusual move, to actually do the delivery at 34 weeks, which is 6 weeks earlier if you have symptomatic COVID infection, because of the fact that you can actually have a severe disease that translates into mortality, even if it's such a small amount. So the recommendation right now, when you get to 34 weeks, if you do have COVID, because of that slight increased risk, is to actually proceed with delivery. So that is not the typical thing that we've always wanted to. We wanted to keep the baby inside as much as possible. But, you know, it is true though, and both anecdotally that I've seen, there is no vertical transmission. We know that it seems that transmission is not, you know, vertical. And it looks like also, and I think that we see this also in non-pregnant patients, that minority population, both Hispanic and African American, are an increased risk for complications. And it's, you know, it certainly is across the board also with non-pregnant patients. Now, some of the complications are that if they do have illness, what do we do with the baby? What do we do with their child at home? So then the question is about quarantine, and then taking care of the baby in the first 10 days following your first symptom. So, you know, it's very difficult to really analyze that. The CDC doesn't have an exact guidelines about that. So it's similar to going back to school. The parents will have the choice of what to do, although it seems to be safer, and that some of the hospitals are doing that, to actually allow that baby to be not with that positive patient for the first 10 days. Because again, I think it's fascinating to read that the majority of patients that have mild to moderate disease will only be, even if they will only be infectious for the first 10 days. If they have severe disease, we found that some between 10 and 20 days they are infectious. So I think that that's what you would see. In terms of ICU admissions and severe disease, I think that what we've learned in the last couple of months, I can tell you in my hospital, and is that you want to keep the patient away from the ventilator. If you can do as much as possible, even if they're desaturating and their oxygen level is low, we found out that intubation has almost as high as a 20% mortality rate, whether you're pregnant or not. So what's happening in the hospital now with care, a lot of these, whether they're pregnant or not, adult, and certainly young people are also admitted to the ICU, and hopefully never a child, that they keep them, even if they have severe disease, as much as possible not to intubate them.
So here, being in the time of COVID, what advice would you give for a couple looking to get pregnant? Any special message?
Yeah, I mean, I think that when somebody would like to get pregnant, it was interesting. I'm going back to the Zika because Zika was something that actually caused congenital anomalies to the developing baby. That means that if you contracted Zika during pregnancy, in the first trimester when organs are being developed, it led to the potential of consequences that include congenital anomalies and the risk of developmental abnormalities and future developmental of the baby and the child. It's different with COVID. We do not have any evidence of really active vertical transmission, and we don't have really any data about being pregnant, contracting COVID, and saying, gosh, there will be a congenital anomaly. So, I think that when somebody, I don't think that I would advise somebody not to get pregnant. I certainly think that that I think they need to take the normal precautions of everything. I will tell you that that kind of tells me what to expect. It kind of leads to what I really wanted to tell everybody is what should we expect in the next year or two with how we take care of either pregnant patients, children, or adults. And I will tell you that I think that going back to the fact that we will have a vaccine one day, is that I think we want to treat this as much as it sounds simple. We want to treat this as something that we're going to have a vaccine for. But in the next year or so, we certainly do not want to try to contract the virus, and we have social distancing, wearing masks, trying to protect ourselves. But I wouldn't tell them anything else except for, please, I think you should try to get pregnant if you would like to.
So the only other question I have for you is, in light of all the stay-at-home orders that we had and the social distancing, et cetera, which started around mid-March, do you obstetricians expect to be a lot busier come December?
There's no question about that. And we've seen it after Hurricane Andrew. We've seen it after hurricanes. We see it 9 months after the holidays, when people spend a lot of times at home. And we see it now. Not only do we know that, because we see the pregnant patients that are pregnant now, and there's a lot more patients that are pregnant now than we usually have. The majority, the largest month, the busiest month for an OBGYN and certainly perhaps the pediatricians for a newborn are August and September. And we predicted it's going to be January and February, which never was. So the answer is absolutely.
Okay, and we'll have the data to prove that one. So I think that kind of brings us pretty much to the end of this evening's program. For those of you who may be listening that weren't able to join because of the limits of the technology, this will be available to full recording as of tomorrow. I'd like to thank everyone for being part of this. I think we got a lot of really excellent information out here tonight. Thanks to our panelists, Dr. Terry Adirim, Dr. Ivy Faske, Dr. Shannon Fox-Levine, Dr. Chad Sanborn, Dr. Tanya Palmer, we'll give you a doctorate tonight, and to Dr. Aaron Elkin. A lot of thanks to Tenna Wiles and Mindy Tingler at the Palm Beach County Medical Society virtual offices for putting this whole thing together. I'd like to remind everyone next week there's going to be an important webinar on Thursday evening at 6 o'clock. It's outside of the COVID arena. It's actually on opioids ethics and the opioid epidemic. We'll have Dr. Ken Goodman, the bioethicist from University of Miami, will be giving the lecture, and there will be CME credits available for that one. So check your email and the med blast from the Medical Society. So once again, thank you everyone for being part of this evening's program, and stay safe and have a good evening.
Thank you.